Joining us today. I'm Dr. Madelaine Feldman, a practicing rheumatologist in New Orleans. I'm with the coalition, I'm vice president of the Coalition of State Rheumatology Organizations, and I'm honored to be the moderator on such an esteemed panel today. As a rheumatologist for 30 years, treating patients with conditions like systemic lupus, rheumatoid, and psoriatic arthritis, I have seen firsthand over the years how pharmacy benefit managers, PBMs, have eroded the doctor-patient relationship. They've evolved from simple processor of claims for medications into entities that now control what drugs I can give my patient by setting up the list of drugs they'll pay for, the formulary, when my patients can take them, basically by setting up utilization management tools such as step therapy. They tell me what drugs my patients have to fail first before they can get to the one that perhaps we knew from the beginning would be best for them. They also control where my patients can get their medications. PBMs create the pharmacy networks and often underpaying independent pharmacists, forcing them not only out of network, but out of business. And as far as expensive medicines go, patients are forced to use PBM-owned specialty pharmacies. Now over 35% of PBM profits come from these specialty pharmacies. We've seen where lower-priced drugs are redefined as specialty drugs, so they can then inflate the price and run them through their specialty pharmacy. And finally, they also determine how much my patients will pay for the drugs. They say you have to pay this copay, co-insurances on the list price of the drug, sometimes as much as 20 or 30%, and then run that through their own specialty pharmacy. Sadly, the system is set up now so that the three largest PBMs control nearly 80% of all prescriptions in the United States. In the late 1990s, PBMs were given safe harbor from the anti-kickback statute to allow them to legally take rebates and other price concessions from manufacturers in the hopes that it would bring down prices. Regrettably, now those legal kickbacks, yes, we can call them kickbacks, otherwise they wouldn't need safe harbor from the anti-kickback statute, right, if they weren't kickbacks. Unfortunately, now those legal kickbacks are based on a percentage of the list price. Yes, PBM compensation is linked to the price of the drug. Clearly, this has caused and created a perverse incentive for PBMs to choose the highest priced drugs for formulary placement. PBM calls this, well, these are savings that we're getting. So do the patients really receive the benefit of these PBM so-called savings? No. They have to pay, my patients have to pay their cost share on the pre-savings list price of the drug. And on top of that, these price concession kickback packages are so lucrative for the PBMs that they have no qualms about changing formularies year over year, and sometimes in the middle of the year, whipsawing my patients back and forth to whatever drug makes the most money for them. I was sent a recording from a self-insured employer consultant of a conversation she had with one of the big PBM pharmacy techs. She called because one of the employees had metastatic prostate cancer, and when he went to the pharmacy to fill his generic medication, he was told only the $10,000 brand would be covered by your insurance. So she called the PBM and spoke to the pharmacy tech, and he said, oh yes, no, the $10,000 drug is covered, but the $350 generic won't be covered. It's excluded from the formulary. Try to explain where the savings are in that scenario to a self-insured employer. Now the big three PBMs are all vertically integrated. Two are owned by some of the largest health insurance companies. The third, CVS, actually bought their own health insurance company, a little company called Aetna. So in addition to controlling the pharmacy benefits for my patients, these vertically integrated entities now control the medical benefits, the specialty pharmacy, the local pharmacies, the clearinghouses, which apparently can easily be hacked, in-house banks that providers often must use in order to get reimbursed, and now some of them actually now are in the business of employing physicians. This vertical integration has been driving independent community pharmacists and now private practice doctors out of business. The New York Times, Wall Street Journal, and now the Federal Trade Commission has recently published several bombshell reports related to PBM practices and the many ways they impact every single American in the U.S. It's clear that PBMs are increasing out-of-pocket costs and lining their pockets at the expense of patients, pharmacies, employers, and yes, the government, both state and federal. The unprecedented bipartisan momentum in Congress over the past year and a half demonstrates the urgency for lawmakers to act, putting patients and their providers before PBM profits. We are here today to discuss the critical opportunity for Congress to address these unacceptable practices. Thankfully, several legislative solutions have been introduced. I'm pleased to introduce you to two of the champions of such reforms. Please welcome Representative Nanette Barragán, representing California's 44th District, and Representative Buddy Carter, representing Georgia's 1st District.
Thank you. Well, I don't know if anybody can see me over here. I'm so short. I need like a step stool.
I was talking about that.
I want to thank you all for being here today, and a shout out to my colleague, Representative Carter, for his leadership. As he likes to say in the ANC committee, he used to say, I'm the only pharmacist in Congress, and he can't say that anymore. I think he's now the second pharmacist in Congress, and he's leading on critical legislation on pharmacy benefit managers, or what's you're hearing as called PBMs. I want to thank our experts and our panelists here today that's also here to talk about the role of PBMs in our healthcare system and the urgent need for policy reform in the area. The reality is, and most people don't even know what PBMs are. The average person has no idea what a PBM is. And when I got to the healthcare subcommittee, I'm like, what's a PBM? So I would say I'm sometimes a little more than an average person. And so people in my district and in the community, they don't understand why prescription drugs are so high, and you start to investigate, and then you learn about PBMs. And today, it's the cost of prescription drugs. That's the significant access that serves as that's a barrier, I should say, to access to healthcare. And one of the most common issues I hear is from people saying they can't afford medication or they have to ration medication. And when they do that, they're going to skip a treatment. Maybe they're going to skip a dosage, and that is a problem because then the medication doesn't work like it's supposed to work, and clearly can cause other issues. And it can also lead to worsened health conditions and increased costs in the long term. About 30% of Americans report not taking their medicines as prescribed because of the cost. Think about that, 30%. That's a lot of people. And I think that shows you why the system and how the system is broken. It's people with an annual income of less than $40,000 that struggle the most to be able to afford their prescription drugs. I serve as chair of the Congressional Hispanic Caucus, so I always have an interest in looking at the impacts on racial and ethnic disparities in drug affordability. And we've seen that Latino Americans are more likely to not take their medications as prescribed at some point because of cost. And so drug affordability is not just a financial issue, it really is a health equity issue. And that's one of the reasons that I'm so passionate about it. Now, PBMs are one significant barrier to access to prescription drugs because PBMs serve as a middleman between the insurers and the pharmacists and the drug manufacturers. And what's been really fascinating to me is when we've had hearings and we bring them in, everybody points the finger at everybody else. But one of the things that's been really great in the last two Congresses is we have seen an effort to work on a bipartisan basis in a polarizing time, trying to look for those sunshiny and those bright spots and where we can work together. PBM reform is one of those areas. And that's why I think it's so critically important that we have this panel here today to talk about what PBMs are, how they work, how they don't work for the American people on bringing prices down. And what we've also seen is a system that PBMs can influence and determine a patient's ability to access and afford their prescription drugs, according to the Federal Trade Commission report released yesterday, which includes overcharging patients for cancer drugs. Now, this has created a pervasive incentive for PBMs to prioritize higher rebate drugs over those that may be more clinically effective but less profitable. Meanwhile, PBMs also steer patients to pharmacies that the PBMs own or are affiliated with. It's a practice known as patient steering. And PBMs can benefit from higher reimbursements to their own pharmacies, which increase costs to the Part D program. And this can drive up the cost for patients and limit access to pharmacies of their choice. Now, these practices harm not only the patients, but also the independent pharmacies. And the FTC report also found that the PBMs hold substantial influence over independent pharmacies, imposing harmful contract terms that can impact independent pharmacies' ability to stay in business and to serve the communities. I represent California's 44th district. It is in the state of California. In 2022, there were over 1,800 independent community pharmacies in California, where my district is located. Just to show you the impact it has and the influence over how many independent pharmacies there are. And those pharmacies filled over 122 million prescriptions in 1 year alone. So community pharmacists play a critical role in greater access to prescription drugs as they offer convenient locations and patient-centered care, often to underserved communities. So policy reform on PBMs is something that's been a hot topic, but we got to get it across the finish line. And so that's why one of the bills I'm proud to co-sponsor is the Protecting Patients Against PBM Abuses Act, which is led by my colleague who I saw walk in the room, Congressman Buddy Carter, who you're going to hear from in a minute. And it's great to be able to partner up, but again, on a bipartisan basis on these issues to tell the American people, this is not a Democrat issue, this is not a Republican issue, this is an American issue, and we're going to make sure we're fighting to protect you that you're getting access to care, prescription drugs, and the lowest cost. Now, this bill would provide patients and pharmacies from harmful PBM practices in the Medicare. It's going to protect patients in the Medicare Part D program. Among other provisions, the bill will remove the incentive for patient steering by prohibiting PBMs from reimbursing non-affiliated pharmacies at a rate less than they reimburse their own pharmacies. I'm also proud to co-lead another piece of legislation with Congresswoman Miller Meeks, again, a bipartisan effort, which is delinking revenue from Unfair Gouging Act or the Drug Act. And this bill would ban harmful PBM practices in the commercial market, such as a ban on patient steering. So there is a huge need for policy reform. I think there's a great opportunity to do that. I think the time is now. If there's a way we can get this done, as there's all these negotiations going to begin to happen with the lame duck right after the election, that this would be a really amazing thing that we could get across the finish line. So patients and community pharmacists can't wait. And we know there's strong bipartisan support. So thank you all for being here. Thank you to our panelists. Thank you for the opportunity to speak. And with that, I'm sure you're going to hear some great stories from my colleague over here, the pharmacist in Congress, the second pharmacist in Congress now, although the first one, Buddy Carter. It's really great to be able to work across the aisle and show people that there are issues where we work together more so than not. And so with that, thank you all for your work.
Representative Carter.
Thank you. How are y'all?
Good to see you.
Well, thank y'all very much for having me here today, and thank Nanette. She is absolutely right. Look, folks, these issues are bipartisan. You know, I practiced pharmacy for over 40 years. I started when I was 10, so that explains that. But I practiced pharmacy for over 40 years. I practiced retail pharmacy, independent retail pharmacy. Never did I go to a counter and say, "Are you a Republican or a Democrat?" That was not even in my mind. What we're talking about here are issues that impact everyone. And when we talk about health care, and you talk about health care in America, we all want the same thing. And when I say we, I mean Republicans, Democrats, Independents, regardless. You want the same thing. You want accessible, affordable, quality health care. That's why these issues that we're talking about are indeed bipartisan. And that's right. We are working. She and I both serve on the Energy and Commerce Committee together. The reason I wanted to be on that committee is that's where the Health Subcommittee is. And that's what I serve on, the Health Subcommittee, as well as some others. But that's very, very important. And that committee is very important to the work that we're doing. Many of the bills, in fact, I didn't hear all of her speech, but when I did hear, the bills that she mentioned are in our committee, in the Energy and Commerce Committees. That is the most bipartisan committee in Congress. We work more in a bipartisan fashion than any other committee, and I wouldn't submit, in Congress. And that's why this is so important. Nanette mentioned something that happened yesterday morning at 8:45, and that was release of the FTC report dealing with independent retail pharmacy and PBMs.
I came to Congress 10 years ago, 9.5 years ago. The first thing I did when I got here was to go to the FTC, the Federal Trade Commission, and ask them to look at the vertical integration that exists within the drug pricing, where the insurance company owns the PBM, that owns the group purchasing organization, that owns the pharmacy, that owns the doctor. Did you know that the largest employer of physicians in America is United Healthcare? 9% of all physicians in America work for United Healthcare, an insurance company. Now, there's nothing wrong with working for United Healthcare, but that's just to my point. That vertical integration is where we have the problem. I describe it sometimes as like squeezing a balloon. When you squeeze it, you squeeze the air, it comes out somewhere else. And this is what happens with this vertical integration that exists within the drug pricing chain. And I would submit to you that it's even more than that. It's not only the drug pricing chain, but it's also healthcare in general. I mean, when you think about it, look at these big hospitals and these big healthcare systems. They're gigantic now. And yes, I would argue that they're not saving money, and I would argue that the accessibility can be questioned because it leads to the closing of a lot of rural hospitals. I'm not going to say anything about the quality. I think that most of them, if not the majority of them, try to do a good job with quality. But at the same time, I want to tell you a story. We had a member hearing, a member meeting. It was not a hearing, it was a meeting of the Energy and Commerce Committee, members of the Energy and Commerce Committee. We had in there the CBO. The CBO is the Congressional Budget Office. They are the economists in Congress. They are the ones who tell you this legislation is going to save you money, this legislation is going to cost you money. They are the economists, so that they crunch the numbers for us. We had the director of the CBO. We had 20 of his staff members. I asked them, I said, give me one example of where consolidation in healthcare has saved money. They could not give me one example. Not one example of where consolidation in healthcare can save money. Now back to this report about the FTC, because that's what I'm going to talk about. That really was significant. This was an interim report. This study started 2 years ago. And the FTC, it's called a 6B study. What they did is they want to look at the impact that PBMs are having on independent retail pharmacies. Remember, accessibility, affordability, quality. That's what we're talking about. So let's talk about accessibility. The most accessible healthcare professionals in America are pharmacists. 95% of all Americans live within 5 miles of a pharmacy. Now, if you start closing pharmacies, particularly independent retail pharmacies, then you're going to impact the accessibility of healthcare in this country. We are on pace this year. We lost 300 independent retail pharmacies last year. We're on pace this year to lose one a day, one every day. That's going to impact accessibility. And much of the reason for that is because of the low reimbursement that PBMs are giving and insurance companies are giving to the independent retail pharmacies. Much of it has to do with the patient steering that Nanette mentioned. That these companies are steering, these insurance companies are steering the patients to their own pharmacies, particularly when it comes to specialty drugs. The interim report that was issued yesterday, and again, it's the interim report. It is not the final report. We hope to have the final report within 6 months to a year. It just depends on what the FTC can get done and the information that they can get from the PBMs. I will tell you that they're struggling a little bit to get that information, but that's what will determine when the final report will come out. Now, the FTC is made up of 5 commissioners, 2 Republicans, 2 Democrats, and then a chair. And it is supposed to be a bipartisan committee. It was a bipartisan vote to pass this interim report. There was 1 Republican commissioner who voted against it. But I want to make sure you understand the reason she voted against it is because she didn't feel like it went far enough. She didn't think it showed enough about the impact, the negative impact that PBMs are having on independent retail pharmacies. So we're working with her to try to get more information, more teeth into this report, if you will, so that when the final report comes on, it will be unanimous. And that's going to be very important. So that's what happened with the FTC report. That is extreme. That was big news, especially for me after working all these years to try to get the FTC to finally look at this. Once we can get that now, what happens? If we get that final report, we're going to have congressional action. That's going to be one of the things that is going to be very important. But hopefully we'll see them to bust up. It just so happened that they released a report yesterday that the FTC was before one of our subcommittees in Energy and Commerce yesterday. I had the opportunity to wave on to that committee, it's the IDC committee, and I had the opportunity to wave on that committee and to ask them about the report. But that's something that we are going to have to address in Congress. And I want to tell you, and I don't want to be repetitive, Nanette went over a lot of these bills. She told you about the drug transparency and Medicaid. Jack was drug price transparency in Medicaid. What that is, this is Jack Dienter. He's my healthcare LA. And yes, he is extremely smart about this subject area. And I am too, because I'm a pharmacist, but that's all he's got to keep up with. I got to keep up with everything. I'm not going to beat myself up when I have to ask him about the title of it. So anyway, that is an important bill because what it does is it will prohibit spread pricing in the Medicaid program. It'll save billions of dollars if we can get this passed. And it will lower drug price if we can get it passed. You know what spread pricing is? Spread pricing is when the insurance company, aka the PBM, they charge $10 for this medication, yet they only paid $5 for it. Well, that's the spread right there. That's what we're trying to eliminate. That's why we need transparency. We need to know. We also have another bill. It's called the PBM Accountability Act. What that does is that it will give employers, it's a transparency bill. It will give employers and plan sponsors the opportunity to see that kind of information. Once they see that kind of information, I think they're going to demand action here. They're going to demand that the PBMs, aka the insurance companies, same thing. They're going to demand that they get some of those rebates and some of those discounts, as they should. So those two bills were included and have been passed out of the House already. What we did is we took these two bills along with, how many were there, 27? Well, something like that. Anyway, we took all these bills and we put them together in a package, and we called it the Lower Cost, More Transparency Act, and a number of other things in it as well. It passed out of the Energy and Commerce Committee, it passed out of the Ways and Means Committee, and the Education Committee, and then went to the floor. It has passed the House of Representatives. It is sitting over in the Senate now, where all good bills go to die, and that's what's happening with it now. It's gathering dust over there. That's why we need to be pushing the Senate to act on this. If they will act on it, then we can get something done, something immediately done. We got a couple of other bills that we're working on, the health co-pays bill. This is something that's extremely important. What they're doing, a lot of these insurance companies, you may go to the doctor may give you a discount card. You can get $100 off of this drug if you present that card to them. Insurance companies are not counting that toward your deductible. And then all of a sudden, after you run out of those cards, you come and you're facing this big deductible called copay accumulators. And that is something that's not fair and not right. So what's happening to that $100? The insurance company's putting in their pocket. That's what's happening to it. So that's why we got the health co-pays bill. We got another bill, I believe Nanette mentioned it too, that delinks the compensation. What's the name of it, Jack? Protecting patients against PBM abuse. Yes. And what it does is, right now, I told you about that spread pricing and all. What it would do is it would delink the compensation from that, and it just say that they're just going to get a simple fee. And they deserve a fee. I'm not saying they don't, but they just get a simple fee, so it will kind of clean up a lot of what that's going on. Look, I could stay here all day and tell you about all these bills, and because we have, and I would be remiss, and certainly it would be unfair not to mention the help that Antonia has given us, and thank you so much. He has been a great resource, and thank you all on the panel for this. Again, let me stress this. This is not partisan. This is bipartisan. Everybody wants the same thing. And as Nanette mentioned, I was the only pharmacist in Congress. We got another pharmacist now, Diana Harshbarger from Tennessee. She's doing a great job, a rising star in our conference. So now I'm not the only pharmacist in Congress. I'm just the oldest pharmacist in Congress. But nevertheless, that's okay. We're glad to have Nanette. I'm glad to have Diana up here. People ask me, why are you so Why are you so enthusiastic about this? Why are you so passionate about this? For 40 years, I was the one who had to go to the counter. I was the one who had to tell the patient how much their medication was. I was the one who had to watch the senior citizen as they tried to make a decision between whether they were going to buy their medicine or buy their groceries. I was the one who had to go tell the mother how much the antibiotic was for their child and watch her in tears try to figure out how she was going to pay for it. That's why I said as my goal, as my mission when I got to Congress to do something about prescription drug prices. We are making progress. Tony, wouldn't you agree?
Absolutely.
We are making progress. I know the wheels of the government, they move slowly, but we are making, and Nanette was right, we need to get pushed across this session. We need to get it done. We have got their, as my daddy would say, we got their hand, and we got our hand on their throat. Don't let it off. And we don't need to. That's why your part is extremely important. Advocacy is extremely important. Listen, I'd love to take all the credit for this, and I'm willing, if y'all want to give it, that's fine with me. But truthfully, it's not me. It's you. It's your advocacy. That's what makes the difference. Every day I have somebody come up to me. Another member of Congress. I didn't know you were a pharmacist. I had somebody in my office yesterday said, you were a pharmacist and you got a bill that I need to get on. Or you got a letter that I need to sign on to. I'm going to have my staff call your staff. It's because somebody went to them. One of their constituents went to them and told them, hey, you got a pharmacist who's got a pharmacy bill here. You need to get on it. That's what makes the difference, advocacy. So thank y'all very much. Thank you for being here. Thank you for the panel. Thank y'all especially for all the work y'all do. These are experts here. We appreciate them. So thank y'all. God bless you.
Thank you, buddy. So I'm really excited to introduce our panelists. We've got some rock stars here. Let's start with Antonio Ciaccia. He's with 3 Axis Advisors. Next, sitting right next to Antonio is Steve Moore. He's a pharmacist and a board member of the National Community Pharmacists Association. Then we have Amy Hinojosa. She is a MANA, yes, MANA, National Latina Organization. And then immediately to my right is Alex Oshmyansky from Cost Plus Drugs. He is basically the founder, CEO. I'm sorry to say Cleola Brown couldn't be with us at the last minute, so she is in your handout, but unfortunately she couldn't be with us. We're really hoping to have sort of more of a free-flowing conversation here. So any of you, please feel free to chime in on anybody else's questions, and let's dive right into these discussion questions. You know, I'd mentioned, and a couple of people have mentioned, the New York Times investigation, which includes several examples and many examples of harmful behavior by PBMs. And all the way to my right, Antonio Ciaccia was quoted in there, basically saying, I want to make this, I get this right, the PBMs are the arsonist and the firefighter of high drug prices, kind of like the fox and the hen all at the same time. Can you kind of explain that a little bit more about PBMs?
Yeah, absolutely. By way of background, I'm from Ohio. I didn't know what a PBM was back in probably 2015. And in my time in Ohio, we encountered a problem with a practice called spread pricing that Congressman Carter referred to. That's when a PBM pays a pharmacy one rate, they bill a different rate on the same claim and pocket the difference. In our home state of Ohio, pharmacists were complaining about underpayments in our Medicaid program from PBMs that were operating on behalf of the Medicaid insurance plans. When we brought the issue to the state, they said, we don't know what you're talking about. We're paying for more for drugs than we ever have. And so those two things didn't make sense to me. How can pharmacies be getting paid less, but the state getting charged more for the same drugs? Well, we started downloading very boring Excel files off of CMS's website and stitching together a story of what was happening with the real costs of drugs and what was happening to our Medicaid program. That prompted an investigation by Bloomberg News and the Columbus Dispatch locally. That prompted a state audit from our state auditor, now Attorney General Dave Yost. And they found $245 million of gap between what pharmacies were being paid and what PBMs were charging the state. Now, to be very fair to the PBMs, not just on this issue but others, PBMs are saving money. They're saving a lot of money off of bogus inflated prices that they helped incentivize in the first place. So drug companies, when they're in competition with one another, they don't compete to lower their prices. They compete to increase the amount of kickbacks back to the PBMs and insurance companies and government programs in exchange for covering those medicines. So competition has an inflationary effect on price where it becomes artificial. PBMs are saving a lot of money off those inflated prices, hooray for them. But it begs a question of what is the actual underlying cost of a drug relative to what a PBM is charging. In the world of spread pricing, where they're buying low and selling high, when they buy low, that means they've successfully negotiated a great discount in terms of their reimbursements to a pharmacy. But they're playing the float. They are allowing for a significant gap to live over top of that negotiated rate and passing along inflated rates to the end payer. So yes, they are lowering costs for themselves, but much like every member of the drug supply chain, they want to make a markup, right? And as Congressman Carter says, PBMs absolutely do provide some crucial service within the drug channel. But the question remains, what is the value of that service? And is the compensation commensurate with that value? And secondly, are there other collateral harms that we have to deal with in order for them to extract that value, i.e. the higher list prices that we have to face, the higher usual and customary prices that people see at the pharmacy counter, and the higher costs that employers and government programs have to pay along the way?
Wow. What about things like unions? I mean, how do they, you touched a little bit on how they increase costs for example, self-insured employers, where the company, all of the healthcare costs are actually paid by the employer. How are they driving up costs for some of the union-sponsored health plans?
Well, a little history lesson that actually predates myself. PBMs were actually architected out of trade unions as part of the very first collective bargaining with the United Auto Workers back in the 60s. It became obvious that medicines were such an important component of our overall health and wellness. And so union members started prioritizing, hey, these medicines are really important. They also lower our medical costs. We want coverage for those things. And so PBMs were brought in to facilitate coverage of those medicines, which was a good thing, bridging the gap of access between those who want medicines covered under insurance benefit and then procuring them from a local pharmacy. Over time, though, just as PBM relationships with government programs and employers have become increasingly complicated and conflicted, the same occurs within the trade union space, where trade unions are also plagued by a lot of the problems that we see in government programs and employer sector plans. As an example, we did an analysis last year examining costs that a trade union was incurring on specialty drugs. If you're unfamiliar with what a specialty drug is, it's highly ambiguous, but for simplicity's sake today, let's just say it's the expensive stuff. And specialty drugs were a huge drain on this trade union. Well, when we performed our analysis to look at what they were being charged on specialty drugs, what we noticed was that there were a lot of very cheap generic drugs in this bucket of supposedly the most expensive products in the marketplace. Well, they were expensive, and they were expensive because they were being marked up significantly. And where were those drugs being dispensed? Through pharmacies that were owned by the PBM that was servicing that trade union. So PBMs can do a really good job negotiating low costs for independents like Steve or others across the country, or even chain pharmacies. But they all of a sudden find their metaphorical kryptonite when they're negotiating against themselves, when they have to drive a hard bargain on the drugs that are being dispensed at the companies they own. All of a sudden, their powers start to become highly diminished. And so what that means for a trade union is that they're being significantly overcharged by medicines that members are being told must be filled at a pharmacy owned by a PBM. So the patient has no choice in the matter, and the plan is essentially locked in to this self-dealing scheme.
Wow, there's a lot going on over there. Let's move over to Steve. Steve Moore, he's an independent pharmacist, board member of NCPA. I mean, why don't you just, and this is a very broad question, so take it wherever you'd like to take it. Kind of give a brief overview how PBMs have impacted your ability to take care of your patients that come to your pharmacy.
Yeah, absolutely. And Dr. Feldman, thank you for having me today. I'm really honored to be part of this panel. The people on this panel, just so you all know, are doing some great work in this space. So I encourage anybody and everybody to heed their words, not only today, but in the future. Appreciate everybody being here today. This is not an easy topic to get your arms around, and it's something that we've been talking about as pharmacists for decades now. So it's great to come here and not have to define what a PBM is. I'm thrilled that people understand that and recognize the need for reform. Everything that everybody has said so far is absolutely true. PBMs, I'm a second-generation pharmacy owner. I'm from Plattsburgh, New York. They're negatively impacting my ability to take care of my patients, just like they're doing to my colleagues throughout the country. By way of background, Condo Pharmacy is a traditional community pharmacy. We do a little bit of traditional stuff. We do long-term care. We do specialty. We do compounding. Anything that we need to do to take care of the patients in our community. We'll do clinical weight loss. We'll do point-of-care testing. We'll do immunizations. We'll do durable medical equipment. We work with providers to do annual wellness visits, chronic care management, and transitions of care programs. We do this both in the pharmacy and outside of the pharmacy in our community. We're working to bring pharmacogenomic testing to our patients in 2024, along with diabetes self-management, education, and support programs. So we're not just a pharmacy that sits back and puts pills in a bottle. That's not what I went to school for. That's not what my team went to school for. Despite all of this, despite all the stuff that we can do, that we want to do, I can tell you that if we make it to 2025, I'm going to be thrilled. The PBMs are absolutely killing us right now, and I'm not the only one that's facing this problem. We're losing an independent pharmacy a day. The PBMs, or you might have seen some of their rebranding efforts, their PBCs, whatever their PR departments say that they want to be called, they're middlemen, and they decide what patients pay, where patients can go to get their drugs, how their patients can get their drugs, what payment we receive. And as you've heard, that's different from what they pay themselves when they have that opportunity. So we're asking for a level playing field. PBMs and their allies purport to lower drug prices through some of these games. But despite this fact, prescription drug pricing continues to be one of the most important issues that we talk about here in America year after year. It's a nonpartisan issue. And while my pharmacy is only, we're a small employer in a small town in upstate New York, but we haven't seen premiums decrease, and we haven't seen out-of-pocket patient costs decrease, whether that's as an employer or whether that's to the patients that I'm talking to. When Representative Carter was talking about patients making decisions on whether to afford medications or food, that happens every day. It's incredibly unfortunate, but that is real life, and that happens every day. So what can we do about this? Costs have increased while these companies have merged. They've vertically integrated to the point where they've climbed their way right up to the top of the Fortune list. The top 3 PBMs are all in the Fortune 16 right now, with 2 of them in the top 7. So they are large companies. How do we fight back? I can tell you that in New York, our Medicaid program, the NYRX program, started by kicking the big 3 PBMs right out of Medicaid. April 1st of 2023, they took over the pharmacy benefit themselves. And this fiscal year, they're projecting to save more than $500 million by doing so. New York, granted, we have a very robust Medicaid program, one of the larger ones in the country for sure, but $500 million a year in savings that have been reinvested to patients and to providers, not only pharmacies, to our health systems, to our hospitals, to our 340B entities, to the provision of patient care. That's what we should be spending our dollars on. So for this reason, we've talked about some of the legislation, H.R. 5378, mentioned by both of the representatives, passed the U.S. House of Representatives in December. And I will point out that the CBO scored that bill with a savings of $1.1 billion over 10 years. Based upon our experience in New York, we really feel that that's an underestimate of the potential savings that this group's going to see. So kudos to Congress for passing that. We hope to see it actually signed into law, passed in the Senate later this year. Pharmacy contracts with PBMs. They're provided on what we call a take it or leave it approach. So whether I'm a single independent provider, my N equals 1 in Plattsburgh, New York, or I'm working with a larger group to help with my contracting, such as a PSAO, we're presented with a contract, we try to negotiate, we're told too bad, that's the contract, that's the way it is. It's amazing that pharmacies across the country are getting the same declinations and the same exact, email saying, hey, this contract is what it is. It is our best and final offer. I can tell you that next month at Condo Pharmacy, in what is certainly not a professional highlight, is going to be losing access to TRICARE. It's been an honor and a privilege to serve TRICARE patients since my family took over the pharmacy in 1994. We're a base community. Plattsburgh Air Force Base existed for a long time. It was closed, but we still have a lot of military personnel. And we're going to lose access to those patients. So definitely not a professional highlight because we couldn't come to an agreement with the PBM that was managing that benefit. In September, we're going to lose access to one of the largest commercial networks in the country because we couldn't come to an agreement with the same PBM managing the same benefit. I simply cannot justify the reimbursement rates they're offering and spending the money to lose money for the benefit of these Fortune 16 companies. So for this reason, we support the reasonable and relevant contract terms that the No PBMs Act that was mentioned earlier as well. It's Senate Bill 2436, and the contract would require PBMs to get approval for what's reasonable and relevant in a contract. It would give pharmacists the ability to appeal the issue to CMS when we have an issue with a contract. Right now, there's really no one to help us out with that issue. We can complain, we can talk, we can come here and talk about it, but really there's no one to actually say to the PBMs, you have to fix this problem. So because of PBMs, as has already been mentioned, thousands of independent pharmacies are closing, but this is not just an independent pharmacy issue. Recent stories talked about Walgreens and a quarter of their pharmacies are unprofitable. We're losing one independent pharmacy a day, as Congressman Carter mentioned, but we're actually losing 3 chain pharmacies a day. So this is not an issue of me being an inefficient business person or a poor owner or an economy to scale issue. This is an issue that the PBMs are actively causing. I could spend the entire day talking about PBM malfeasance. We've mentioned the stories. I believe you have printouts of the Wall Street Journal and the New York Times articles that tell remarkable but disheartening stories about unchecked corporate greed, and it's an industry that is just screaming for transparency and regulation. The FTC interim report yesterday stated that PBMs hold substantial influence over independent pharmacies by imposing unfair, arbitrary, and harmful contractual terms that can impact independent pharmacies' abilities to stay in business and serve their communities. 100% true. So we appreciate the efforts of the FTC and everybody to release that interim report. We're really looking forward to the final version. Anytime a pharmacy closes, it can create a pharmacy desert. I can tell you right now, based upon our experience in upstate New York, if a pharmacy closes in the Adirondacks, there's not going to be somebody else moving in to open up another pharmacy, especially in the case of independents. You know, if you have a chain, they've got their set parameters, and God bless them, they have their business models. But if it doesn't make sense for an independent to open in a small community, it's probably not going to make sense for a big chain to do so. You know, in New York, you also have our big metropolitan areas, whether it's the cities, you've got Rochester, Buffalo, and New York. You could have a pharmacy desert where you just don't have a pharmacy for a mile or so. It's a completely different community from block to block, and those patients rely on those pharmacies to take care of their needs. I want to be perfectly clear that no one in the community pharmacy space is asking for anybody to spend any more money on prescription drugs. We recognize that enough money is already being spent. We're asking for help reallocating the dollars that are being spent to the provision of care. So just some things to close with as somebody who deals with patients every day face to face. Like I said, I'm a second generation owner, so we've been taking care of, you know, grandparents, parents, children, and now in some cases great-grandchildren at the pharmacy since I've been involved. It's an honor and a privilege. But right now we're reducing staffing levels, just like my colleagues throughout the country. You know, we're reducing our hours. Are we going to stay open 6-7 days a week? Are we only open Monday through Friday or banker's hours? Access is an issue. Services such as delivery and financial aid. You may have a patient charge account where you manage your prescription spending for your parents from, you know, we moved away, but our parents need help. We've got to discontinue that because the cost of it, providing it isn't covered by, you know, the prescription markup that we receive anymore. Credit card fees. If we take credit cards, pharmacies starting to pass those fees on to consumers and patients throughout the country. Pharmacists are declining to participate in below-cost contract offerings, really worried about what we're going to see in the Medicare Part D space for access next year. Pharmacists are falling behind on their mortgages. I hear from my colleagues throughout the country. Wholesaler payments and other bills, trying to open lines of credit, tough to get from the banks when you have a business model that is dependent on PBMs. And pharmacists are doing, my colleagues, I love and respect them so much, they're doing everything possible, often at a great, great personal financial risk, to keep their pharmacies open and continue to take care of their patients. This is just a few years after the COVID pandemic that reinforced pharmacists' position as frontline healthcare providers, and it will take years, if not decades, to undo the damage that the PBMs are causing. We cannot get blood from a stone. There's no more to give, and many of my colleagues are out of time. Community pharmacy, at least what is left of it right now, remains eager to work with Congress. So thank you for being here today and listening to us, but I can tell you that we are out of time. Congress must pass legislation to immediately reform PBM practices, and this legislation must be signed into law this session. We are out of time. So thank you again. Appreciate the opportunity to talk and always here for
Thank you, Steve. You know, the same story, believe it or not, is now starting to happen with physicians. A friend of mine in a sort of area of California, United Healthcare came to them with reimbursement rates that couldn't survive. Pulled out, guess what happened? United employed physicians moved right in. So the same thing is happening, and if we let these vertically integrated entities continue like this, everything's going to be owned by 3 big companies. So, speaking of which, I take care of a lot of Latina and African American patients, particularly with systemic lupus, and they have a very difficult time getting the right medications, particularly if they're in a high deductible plan. Representative Barragán talked about adherence. Adherence is extremely important, particularly in patients with chronic disease. And I know you sort of specialize in these areas with health inequities. How are the PBMs exacerbating the problems we see already in underserved areas?
On a fundamental level, what we're talking about is a very simple pocketbook issue, right? We're talking about, are folks able to afford the medications that they are prescribed? And are those medications accessible to them, right? And is the system accessible to them overall? So I run a National Hispanic Women's Organization, MANA, but we also lead a coalition called the Health Equity Collaborative, which is over 50 national organizations, Hispanic, African American, patients' rights groups, civil rights groups. And the point being that, and we raise issues, top-line issues with each Congress on the issues of health equity. Cost of drugs are right at the top of the list, right? Because that's exactly what people think about day to day. That's part of their weekly, monthly budget. And so if I'm looking at it through, while we're talking about, in many ways, when folks think about equity, think about diversity, inclusion, those issues are a little bit of hot topic. They're a little nuclear right now. But you need to understand that we have a broad tent of who we're talking about. We're talking about underserved communities. We're talking about rural communities. These are not just people of color. This is why this is a bipartisan issue, because it impacts all of our communities. Now, poorer folks are disproportionately impacted. That's not just people of color. And so when, folks who work in offices here on the Hill, I want you to think about that when you're thinking about whether or not to sign on to these pieces of legislation. They impact your community. The pharmacies that Steve was talking about are not just in Black, Hispanic. My lane is Latinas, however, right? So if I could give a couple of examples of how Latinas are impacted. We have among the highest rates of obesity, diabetes, chronic heart conditions, right? And all the things that follow along. It was one of the reasons why COVID was so devastating to the Latino community, right? Because all those underlying conditions existed and were not treated fundamentally throughout. The Congresswoman told you 30% of Americans are not getting their medications, right? Either not getting them, foregoing them, or taking them irregularly based on when they can afford them. If you have a chronic condition that needs continual care and you're not getting your medications because you simply can't afford them, it's sort of antithetical to everything that the ACA was invented for, right? It was about, care up front to make sure that you had continual care. If you're not able to actually see that through with your medications, we're still going to end up in the places that we were before, where folks are just going to get to the point where they need emergency care. That costs more in the long term. So it's not just pocketbook for families, it's pocketbook for the industry. And what we have are these folks in the middle, right? Everybody hates a middleman. I always say that, folks aren't mad at who they think they're mad at, right? We sort of had this big bubble of big pharma is the bad guy and making everything, terrible in your lives. And this is why you can't afford your medications. Everybody misses these folks in the middle, these PBMs, who are really increasing their profits and taking money out of their pocketbooks, taking food out of their children's mouths, taking away their ability to live healthy lives, right? So the Latinas in particular, right? So if we're talking about elderly Latina patients, and we think at MANA that your financial health is inextricably linked with your overall health, right? Your physical health. And so the average Latina in retirement, the average Latina who is receiving Social Security receives a benefit of between $12,000 and $14,000 a year. So think about that in terms of chronic conditions as you age and get worse over time and you need more treatment, you need more medications. How can you conceivably increase the amount with $1,000 a month? How can you possibly survive and get the medical treatment that you need and access the medications? So when Steve talks about urgency, there's urgency for business, certainly. But we need for them to survive because that is inextricably linked with the survival of our communities, right? And so while my examples are Latinas, this is for all poor, underserved communities who are just not able, it's just out of reach, while these PBMs are sitting here like fat cats with their profits increasing and they're taking the bulk of that money and what's intended for prescriptions to be, far more accessible and far more affordable. And so, when we talk about reform, you're talking about pocketbook issues that could impact people right now. Think about how all the conversations that are going on around inflation and how folks are trying to make ends meet. This is one of those things that could put money in their pocket right now. Folks wouldn't have to decide between eating and taking their medications like the congressman talked about. And the biggest example of this really is, and the federal government stepped in, it was a bipartisan way of doing it, and said, I don't care what your industry has to do, you're not going to charge a consumer any more than $35 a month for their insulin so that they don't have to go without their insulin treatments. Guess what? The rest of the industry followed suit, right? It wasn't just the folks who do business with the federal government. And so this is the power that we have, but it also is responsive to the urgency of what people need to survive. This is a matter of survival, life and death, literally. And this is where we can make an immediate change that makes a difference in people's lives.
Absolutely. And what you talked about, the long-term costs, in my case, if my patients, and many of them just don't take the medicines and don't tell me, but then they come in and their arthritis is flaring, their lupus is flaring, then we have to put them on a stopgap prednisone. More prednisone leads to sepsis, ICU, more cost to the system in the long run. So adherence costs billions of dollars. Pay a little bit more up front, take a little bit less profit, Mr. PBM, and then you can really help save money for the healthcare system. Antonio talked about some of these drugs that were actually generics, but the costs were inflated and sent through the specialty pharmacies of the PBMs, and yet some of these drugs were really very inexpensive, but nobody knew anything about it. There's been all kinds of new sort of models in how to actually get lower-priced generics to the people. So, Alex, why don't you tell us what you guys are up to at Cost Plus Drugs?
Yeah, absolutely. So, Alex Oshmyansky, Mark Cuban Cost Plus Drug Company. Just a level set of baseline, kind of how I describe to the lay public what PBMs do is imagine you want to buy a car. You want to buy a Toyota Camry. And you're like, you know what, I hate negotiating. It's miserable. It sucks. I'm not good at it. Someone comes up to you. Is like, I got a deal for you. I am a professional negotiator. That's all I do. I negotiate. I'm good at it. I buy in bulk. I'm going to get you a better rate anyway. The only thing I ask of you is whatever discount I negotiate, I get 10% of it. And hey, even better, that aligns me with you, right? Because like the better I do negotiating, like the more I get paid too. And you're like, you know what? Okay, let's do it. Like I don't want to go to the dealer. They're sleazy. Let's make it happen. A week later, the guy comes back and is like, fantastic news, amazing news. I got you 90% off of your Toyota Camry. 90%. And you're like, wow, that's amazing. How'd you make that happen? And he's like, don't think nothing of it. It's my job. It's what I do. Turns out list price on the Toyota, $1 million. You're out not just $100,000 for the Toyota Camry, but $90,000 for the fee you owe the negotiator. You're out in $190,000 to the negotiator. And not only that, but the dealer actually is only getting the real price of the Toyota. They're only getting paid $30,000. So of that transaction, the dealer gets $30,000. The negotiator gets, what is that, $160,000. You're out $190,000. And that's like when people say, like they look at our website And one of the initial things we got, because, Mark Cuban, celebrity, there's all these like keto gummy things on the internet that claim to be from him. It's fun working there. But one of the big questions we got initially is this just a scam? Because I'm on chemo, my deductible is $5,000. I'm getting asked to pay $2,000 a month until I hit my deductible, and it's $30 on your website. Exact same drug, exact same manufacturer. And here's the thing, not only that, we pay more. We're a small company of 60 people. We don't have the negotiating leverage of CVS Caremark. So even we are paying more, I absolutely sure of it, for our imatinib, our abiraterone, and yet our price is 1%, less than 1% in some instances, of their price. So back to that example of the car dealer, not only does the car dealer or the car negotiator, they also own the dealer now. And not only that, they're going to the car maker, they're going to Toyota and saying, you owe us fees. You owe us money for the privilege of me negotiating with you. And the extent of the scams is just so enormous. The way I think about it now, you remember Bernie Madoff? One of the reasons he was able to get away with what he was doing is what he was doing was just so enormous in scale, no one could conceive of it as a scam. It has to be something real. Exact same thing is happening here. It's really easy to get lost in the weeds of all these scams. By the time you say pharmacy benefit manager, people have already fallen asleep, let alone Swiss group purchasing organization rebate aggregation platform. There's so, Antonio and I will be here for a while. We can go into the nitty-gritty details of all of these little scams, but cumulatively the big picture I want everyone to take away with is this is all a scam. From top down, it's a scam. They're driving independent pharmacies out of business. Mark's fond of saying they're shitting all over independent pharmacies, pardon my French. But basically what they're doing, 19th century robber baron tactics, hey, we get to pick what our competition gets paid. Surprise, surprise, their competition doesn't get paid much. They get driven out of business. They either buy the pharmacy or replace them. And it is extremely urgent in the case of the community pharmacies. There are statistics, about 30% of independent pharmacies may go out of business this year. This is not an accident. This is intentional actions on their part. And we need to do something now. Okay, sorry, I get on my soapbox real easy and start rambling. I guess this is a good place to do it, if any. But yeah, thank you everyone for your time.
I have a lot of patients that, they were paying very inflated prices for their medications, and I introduced them to cost plus drugs. It's in our electronic health record. My patients are saving 50, 60, 70%. And this is something that's out in the open. It's not like it's hidden away somewhere, like it's a secret kind of little pharmacy. And there are many independent pharmacists that also give very, very low prices. And yet somehow there was that self-insured employer was getting ready to pay $10,000 a month for a pill that could have been, I don't know, what do you guys sell a Bitarone for now?
$100.
$100. And yet, the Chamber of Commerce, which has a lot of their support from insurance companies, are not necessarily always for these kind of bills and reform because of who is behind the chamber. And yet self-insured employers are getting hoodwinked and paying much more for drugs for their employees than they need to. And Antonio, there was, go ahead, Steve.
Oh, no, I was going to say, it's sort of a weird coalition we're kind of putting together. Sorry, guys, I'm a jerk. It's kind of a weird coalition we're putting together because it's the most vulnerable members of society and the most powerful. And what I mean by that is, it's the individual patient. We get letters from patients all the time saying things like, I thought I was going to have to sell my house to afford my chemotherapy. To the congressman's point, I was skipping meals to afford my therapy. I just thought I was going to die because I had no way to afford this. So it's those patients, but it's also the CEOs of major corporations, because who's ultimately paying a lot of these bills? It's the payers, it's the self-insured employers. I remember I was talking to the CEO of a big oil company, and he got visibly red in the face when I was going over how much his organization was being overcharged. So it's a tax on not just the most vulnerable patients, it's a tax on the entire United States economy. I'm going to estimate about 30% of the money we spend on drugs 30% of the $400 billion we spend on drugs, total waste, total scam to these intermediaries. The scale of this is extraordinary. Sorry, Antonio, took it away from me.
I mean, Nanette talked about, the finger pointing. Yes, I have a slide when I lecture on PBMs about the manufacturers. They say, oh, it's the PBM's fault. The PBM, oh, it's the manufacturer's fault. And somehow people feel like they have to be in a camp. And if somehow you're going to try to share the blame for drug prices over to PBMs, oh, you're in pharma's pocket. No, there's a lot of blame to go around. We have a drug pricing crisis, but I think we could get rid of a lot of it if we could deal with the formulary construction crisis, with the higher drugs getting preferred place on the formulary.
Yeah. And, pharma, I don't think I'll shock anyone or offend anyone by saying, everyone's guilty in drug pricing, nobody's innocent. But at least pharma makes the drugs. Like, at least you get insulin at the end of the day. Like, the PBMs fundamentally are payment processors. Imagine Visa, MasterCard, instead of charging, like 2% or whatever, charge 30%. That's basically what's happening.
Antonio?
Yeah, so one of the
We
things...
look alike, so you could just think I'm
solve
Antonio's
the
talking.
problem
Yeah.
for us today.
Well, no, I mean, at the end of the day, it's a question of incentives, right? On paper, this system should work, right? A PBM is acting as a necessary counterweight against publicly traded companies, drug companies, wholesalers, pharmacies, who all want to make more money off the selling of drugs. Alex mentioned that independents are obviously not doing well. Well, in my home state of Ohio, Rite Aid just announced they were selling all their pharmacies and closing them down. The same is happening in Michigan. Pharmacy chains are closing. Walgreens just announced that even though they're buying Rite Aid pharmacies, they're closing some of their own. You have an entire market contraction that's happening right now in the retail space. And what's driving that is that, as Alex alluded to, PBMs have become price setters and price takers. They get to set the prices for themselves, the pharmacies they own, and set the prices for the pharmacies that those pharmacies compete with. And surprise, when you do the numbers, we just released a study in the state of Washington that examined what employers were getting charged at PBM-affiliated pharmacies relative to other pharmacies. And what you see is that the markups are 3 times as high at PBM-affiliated mail and specialty pharmacies than what is being yielded through independent, mid-sized grocery pharmacies and large chain pharmacies. So it's rather simple, is that when you are a price setter and a price taker, an obvious conflict of interest arises where you can start making money off the inflated, opaque prices of medicines. And so as a theme that we counsel all of our state Medicaid programs on, all the state attorney generals that we work with and state auditors on, is that the process is quite simple. You cleanse the system of its conflicts. Make sure that the intermediary that you hire to make your drug costs lower don't make more money when drug prices are higher. And obviously there's a lot of detail that goes into that I think a lot of these policies get to, but that is the overarching theme, is that we need a lot more transparency and a much better incentive alignment than in the current system we have today.
That's right. De-link the compensation from the price of the drug. When the price of the drug goes higher and the PBM makes more money, who are they going to prefer on the formulary? Not the $350 generic, but the $10,000. So as you can see, it's an urgent issue with community pharmacists. Soon you'll see it may become an urgent issue with private practice physicians as well. But the most important is that it affects the patients. It affects what they can, whether they can take their medicines, and in some cases whether they'll live or die. And I know that sounds rather dramatic, but it's true. And it's the same. It's whether community pharmacists are going to live or die. So this is not, oh, well, let's just deal with it in a few years. These resolutions, these pieces of legislation are important, and it's something that we need to get done, as was said a little bit earlier this year. Unfortunately, we're a little bit over, but if any of you have any questions, the panel is going to hang around a little bit later, afterwards. So if you have any individual questions, I'm sure they'll be happy to answer. But thank you so much for hanging out and staying a few minutes later, and go forth and have fun. Thank you.